So during the MDS 2020 meeting, the MDS Foundation meeting who took place in Tel Aviv, beginning of March 2020, I was asked to give an idea of what were the perspective of treatment of lower risk MDS patients, and especially patients who should receive lenalidomide and immunosuppressive treatment. So these two aspects of treatment of lower risk MDS have been addressed by myself during a long talk, actually, because lenalidomide is used since several years, since almost 20 years, I would say, 15 years, in DAL5Q MDS patients who are transfusion dependent. And the novelty in my talk was not the fact that we already know that this patient do not respond to EPO, and that's why instead of ESA, they receive treatment with lenalidomide. But the fact that, as we know since some years, patients with MDS deletion 5q who have a mutation in the TP53 gene are the ones who respond less to lenalidomide and have a shorter duration of response to lenalidomide. Now, this is a fact that is well known. It has raised question also regarding the opportunity to treat at all with lenalidomide patients who present these mutations. But the most important fact that I brought to the attention of the audience is the fact that not all the TP53 mutated patients are equal. Some patients have multiple hit mutations, and some other patients have monoallelic TP53 mutation. Now, this difference means that the burden of mutation is quite different. And the patients who have a monoallelic TP53 mutation do respond much better to lenalidomide in terms of overall survival. So the actual phenotype and disease history in TP53 mutated DAL5Q patients is different depending on the type of mutation they got. So I think this is a very important message, and we should implement our routine practice by differentiating the different TP53 mutation. So this was, I think, a very important point to stress. And then the use that is off-label in almost all countries of lenalidomide in transfusion-dependent non-DAL5Q MDS patients. I published several years ago the results of the international phase 3 trial comparing placebo to lenalidomide in transfusion-dependent MDS, non-DAL5Q MDS, and with lenalidomide. And the results were indicating that the percentage of patients, 27, almost 28% of patients could become transfusion independent upon this treatment. So these were the old data. And at that stage, we also knew that patients who had lower endogenous EPO level could indeed respond much better. If the level was below 100 units liter, they could respond almost in 45% of cases. Now, the idea is that this treatment that is not ideal for all non-DAL5Q patients could be reserved to a subgroup of patients who have some characteristics that we are looking for. And that's why I presented the data of the molecular characterization of these patients. And what came out of this study analysis of somatic mutations is the fact that patients who have SXL1 mutations do not respond to lenalidomide, whereas patients with E8H2 and DNMT3A mutated are the ones who tend to respond better to lenalidomide. Now, the number of patients with such mutation was not so high, so the statistical evaluation is limited. But what is more interesting is the fact that if you take patients with DNMT3A mutation and compare them, the ones treated with lenalidomide to the ones treated with placebo, you see that the overall survival is significantly better for the ones receiving lenalidomide. This is really very important, I think, and it is consistent with what had been shown before for Len in non-delta Q by the French group. Now, of course, this is a limited number of patients, but I still think that if you may characterize and select patients, you have another important option to obtain transfusion independence in these patients who have no other opportunity apart from transfusions. So I think this is quite an important finding. What I also addressed in my talk was the use of immunosuppressive treatment. Now, immunosuppressive treatment has been used since a long time in MDS, as well as in aplastic anemia. And in fact, it was, I think, a derivation of this use in aplastic anemia. Patients who have marrow failure because of MDS sometimes have a hypoplastic marrow, and they are very similar in fact to aplastic anemia. But the problem in evaluating immunosuppressive treatment in MDS is the fact that many studies have been carried out without selecting patients, with a very heterogeneous patient population, sometimes high risk together with low risk. And then endpoints have been as well heterogeneous, and therefore deducting the results is somehow difficult. So efficacy is present. There have been a couple of meta-analyses recently published that show that the immunosuppressive treatment is useful in patients with hypoplastic marrow, younger ones, receiving ATG plus or minus cyclosporine. And this is very important because we may indeed, again, select a subgroup of patients who has a great advantage from this therapy. Almost, well, I would say more than half of the patient would improve their hematological status by receiving immunosuppressive treatment. Now, it's not so much used. It's underused, underemployed in MDS, both because patients are elderly and ATG is quite toxic, and the fact that hypoplastic marrow ones that seem to be the ones responding better are not the majority of patients. And the fact that also literature is for the moment scarce. Another option could be treatment with cyclosporine, but that's also something that we should explore further to establish which ones are the patients that may have the greatest advantage from this kind of therapy.